With this, we move on to the last session of today's scientific fiesta. And the topic for the last session is newer therapies in stroke management. To speak on this particular topic, I would like to invite Dr. Apratim Chatterjee. He is an interventional neurologist and stroke specialist with an overall experience of more than 11 years. He specializes in neurology and epilepsy. He is attached to Manipal Hospital, Mukundapur. To chair this particular session, I would like to invite Dr. S.K. Somani. He is a very senior neurologist with more than 42 years of expertise in this field. And he is a member of Scientific Affairs of Howrah Town Diabetes Study Society and also the founder member of this organization. Along with him, I would like to invite Dr. Arindam Ghosh, Clinical Lead Neurology, Narayana Super Speciality Hospital, Consultant Neurologist at Sri Aurobindo Seva Kendra. He has several publications and authorship of book chapters to his credit. I invite speakers, sir, and the chairpersons for this session.
Thank you, organizers. Apratim requires no introduction. He is an exceptional strokeologist, has been one of the pioneers of interventional neurology in the city of Kolkata, and he's now interventional neurologist associated with Manipal Group of Hospitals. He's vascular lead, I think. Apratim, over to you.
Thank you so much for the kind introduction. The last session perhaps, newer therapies in stroke management. Now, what is new? So we all, this is a diabetes conference, and this is one of the commonest risk factor associated with this disease of stroke, and how diabetes can change the presentation, the management, and the outcome of stroke, and what is new in stroke. So we all have been knowing this disease and its management since decades, since long. But why are we discussing on the newer management? Yes, because there has been a paradigm shift in the management and the way to approach a stroke patient, especially since 2015 onwards, when the world had encountered the Happy 7 trials. So we will be going briefly into this and moving on to cases so that we get to know how newer approaches change the management. So nothing to discuss more that stroke is one of the most globally prevalent cause of morbidity and mortality around the world, and especially with Kolkata currently having a case fatality rate of around 42.1%, which is supposedly the highest among the cities documented in the country. So we have exactly somewhat similar sort of a course what the cardiologists have seen for AMI cases, and whatever or however you used to treat an acute myocardial infarction way back in the 1980s, and the way they have advanced today with common people knowing that you have to go directly to the cardiac enabled center and maybe directly going for a angioplasty in the middle of the night, primary intervention in the middle of the night. So it's no big deal for even the common person now. Similarly, for the neurologist to explain that, okay, we will be putting a stent or will be, sucking your clot out, it's not very easy job for us, especially for people, because people are not well aware. Still today, people go to a cardiologist for stroke, and they are not aware that even a neurologist can intervene into the vessel in the brain and take the clot out, or put a stent into your brain and can save the vasculature of the brain. So this will take, I think, the similar sort of a timeline which cardiologists have gone through. Now this is our workhorse, the place where we do our work, the cath lab, and we have had an evolution of our devices since 1999, when thrombectomy or taking out the clot meant almost always a complication on table, which we have heard from our mentors. We were lucky that we have had the opportunity to have devices which are as supple, and now we are even discussing about taking clots from distal vessels. So initially it was large vessel, proximal ones, then came the medium vessel. Now we are talking about distal vessel occlusions, directly taking the clot out. Maybe very near future we might discuss, okay, this one to thrombolize, this may not be able to thrombolize before doing the primary procedure. So in brief, the two ways by which we take the clot out, one is the stent retriever. This is the diagram where you can see there is a stent and which actually engages the clot. It traps the clot and takes the clot out from the vessel, occluded vessel. Or it can be in the form of a suction pipe, aspiration devices, which sucks the clot into the aspiration canister. We often do not get such canister in any cath labs, and the most important thing is stroke can be operated in any of your 2D cardiac cath labs. So we often have our aspiration, suction syringes, which works in lieu of these aspiration machines. So in brief, we always have the best outcome with a combination of both procedure. We call it as a solumbra, where we engage the clot with the stent and we try to take the clot out with the aspiration as well. So just going to briefly into the cases. This one gentleman came in the early morning, 6:15 in the morning, when my fellow neurology colleague called me and just sent me this WhatsApp CT scan image and saying that he had a loss of consciousness. He came to the emergency within half an hour of sudden loss of consciousness. Now, as a part of the protocol, CBG was ruled out, so just preceding talk, hypoglycemia was ruled out. Other things were also done, even ABG and everything was done. A CT scan was done, and then the cardiologist had a review, and when the neurologist came, it was already like 3 hours when he was referred to. And once he saw, he advised for an MRI, but he examined the patient and found the pupils were dilated and sluggish reacting. The VOR, the vestibulo-ocular reflex or the brainstem reflex, were relatively sluggish, very high NIHS, very poor GCS. It was supposedly 3. So this was the MRI sent by him. The timeline is noted 9:50 a.m. and you can see that in the ADC you have significant amount of hypodensities in bilateral thalamus, in relatively brainstem areas, so posterior circulation. And in the same sitting he did the MR angio, and you can see a clear-cut cutoff in the mid-basilar segment. Now comes the question. So 5 hours down the timeline, patient came to you within window. We missed it in our emergency, yes. Posterior circulation stroke, basilar cutoff, large vessel occlusion. So what to do? Pupils sluggishly reacting, vestibulo-ocular reflex is sluggish. So the dilemma is, should we open, because how much chance? Yes, the only hopeful thing was this ADC map, because not everything was hypodense. However, given the timeline, we were much beyond, and poor brainstem reflex, we had a very doubt in our mind that whether opening will at all benefit this patient, because after all it's a costly procedure in a private hospital. So even with that 30-40% chance, we went inside and we did first tried a stent thrombectomy. Just by a stent we tried to pull the clot out, but it did not work because stent, once we were putting the clot out and there was a yin and yang phenomena, the clot was somehow moving to the opposite branch of the PCA, but then we tried the solumbra technique and we could achieve somewhat TK2B sort of a recanalization. To our surprise, this was the patient the next day, and you can see that significant, though tracheostomy was done, significantly the patient started to improve. A patient as low GCS as 3 is still working and is still coming to us to inspire other stroke patients, and will retire this year. It's really an eye-opener for all of us that loss of consciousness should be included in the BFAST criteria for stroke code identification in the emergency. So any patient presenting with sudden loss of consciousness, do keep basilar artery occlusion or posterior circulation stroke high up in the list, because if that is so and if we miss or delay, that may be a major catastrophe even if the patient survives. So next question comes that what if the lot of CT scan is hypodense? So this patient came to you, so with a large NIHS, you can see the eyes are deviated to one side. This is one thing we always try to impress our emergency physicians, that if you have a fixed gaze in one side, if you have a dense hemiplegia in one side, and if you have an aphasia, just do a plain CT scan. All you need to do is just a plain CT scan, because you don't need to waste time even with a CT angio. That is a large vessel occlusion if you rule out a bleed. And This was a CT, and you can see a lot of hypodensity. So we do something called as the aspect score in the CT scan, which basically measures the amount of brain already, hypodense. So the aspect was somewhat 6 out of 10. So a moderate sort of an aspect scoring here, and we didn't waste time. But even with this CT scan, you see, patient immediately rushed to the cath lab. First shot, M1 occlusion, single pass, typical gadgets which we take for the Salumbra, and single pass clot comes out, TK3 recanalization. So the patient, this is the patient 3 days later and discharged. The third day discharge criteria works very well if you have a good outcome in the thrombectomy procedure, and this is the patient at discharge, almost nil at deficit at discharge. So even in spite of having somehow moderate sort of an aspects or some more hypodensities in CT, we should not falter. And this is being supported by the latest tension trial, which says that even if you have a poor aspects now, if you have a large vessel, do not deter from opening the vessel, because that ultimately at the end of 3 months does give a much better outcome compared to not opening the large vessel up. So opening the large vessel is no doubt nowadays, even in spite of having hypodensities in CTs. Next, obviously another is, Dr. Saab, kitna age hai? Should we at all intervene? So 87 year, should we intervene? Yes. If you do not open a large vessel, if you do not open a major stroke, the chance of a mortality is 81%. So obviously trying to open is the first priority. There are risks. The higher the age, the chance of complication rises. The more the time you take to reperfuse or delay in reperfusion, more chance of reperfusion bleed or already infarcted tissue happens. However, still then, you see, this was the CT, patient 87-year-old. What are the problems? Problems are the huge calcification and the highly tortuous vessels. So, yes, you have a lot of difficulty, but then we have very beautiful gadgets nowadays, supple catheters, which help us in going very distal into the clot. And single pass, again, you can take the clot out. So this is the TK3 again, and this is how the clot exactly comes out, stuck to the, you can see the stent, and this is the aspiration catheter, which basically pinches the clot between the stent and the aspiration catheter. So even in an 87-year-old, you may have a very good outcome if you can do a nice procedure. So patients like this, in-hospital strokes. This was an in-hospital stroke. Patient was admitted under the gastroenterology department for some other reason. His wife identified the stroke while in the visiting hours, because that was the exact time the patient developed an aphasia and paresis. She started screaming that it is a stroke because her parents died of stroke, and she recognizes it early. Immediately the RMO called. Within 10 minutes, just a CT scan, immediately taken to the cath lab. So don't waste time in unnecessary imaging. If you have a large vessel, if you have a signs and symptoms of a large vessel occlusion in your clinical finding, do a plain CT, rule out a bleed, reperfuse by whatever means possible. If primary cath lab is not possible, thrombolize if within the thrombolyze period. If primary cath lab is available, then go for the opening of the vessel by thrombectomy. So, like I said, age doesn't matter. Patients come to you like this, and just after the cath lab procedure, you have your patients raising your limbs. So all these matters, because not only time but also the tissue matters in stroke management. Now some few points about diabetes and stroke. Yes, remember in diabetic population, ICAD is very, very frequent. And what is bad about ICAD? You have stenosis, which once you open the clot, it again closes down. So be prepared for rescue stentings in ICADs. These are bad diseases, and you may have multiple blockages. Like in this patient, you see there is a blockage. There is only one vertebral artery. The top of basilar, there was a clot, the top of basilar syndrome, and you have to get to the basilar, but you have only one vertebral, which is highly stenosed. So basically you do a balloon angioplasty, you get inside, and then you open the distal clot. So this is how you tackle such sort of a tandem occlusion, which if not opened, have a worse outcome compared to a single occlusion. Now, sometimes even after the best of procedure, you may fail. So improvise the best way possible for the patient. So in this patient, even after multiple thrombectomy procedures, the artery kept on collapsing. It was an ICAD. So what we did was, we just injected IV tenictase directly inside the clot, and you can see you can find a channel by which later you can just put inside the wire and do a balloon angioplasty and recover the whole caliber of the vessel. We now follow the cardiac model, so drip and shift. So you see the distal part. So what is the time window for stroke thrombectomy? It is 24 hours now. Not in all cases, in select cases, but the time window, remember, is 24 hours. So 1 day. 1 day is enough time to travel across, the whole state maybe. And so drip and shift model is very, very useful. So we had a patient, when I was working in my previous institute, we had a patient in Howrah, and that patient came to the nearest nursing home, was thrombolized there, and was shifted in the middle of the night to a primary thrombectomy facility, and there the thrombectomy was done and immediate. So this is sort of model, because thrombectomy facility cannot be made available at every nook and corner. So drip and shift like cardiology is the way out as per the latest guidelines. Now, so this is in brief. Now just few slides more. So not everything is ischemic, some things are also hemorrhagic, and when you have something called as a subarachnoid hemorrhage like this, so do remember that stroke may not only be ischemic, so do remember that all bleeds are not hypertensive. Some bleeds will have some other causes, like in this patient, subarachnoid hemorrhage, and we all know that clipping is one of the oldest techniques to deal with aneurysms, but now you have the endovascular coilings which have changed the paradigm shift towards management of such aneurysms. And what we do is we just put in a catheter, and inside the vessel we put in platinum coils. We try to shred these bulgings from the main vessel and close it off. We can do it in various ways. We can do it by simple coiling. We can do it with something called a balloon assisted coiling, or something called as a stent assisted coiling. So these are some of the Y stent, and especially now we have the advanced bypass stents called flow diverters. These are very fine meshes which in aneurysms which have very bad neck, difficult for the surgeons to intervene, we can just place this sort of stents and come out, and the patient and the vessel really heals, as you can see after 3 months. So these are actually flow remodeling devices, and they have changed the paradigm. You see this aneurysm. This aneurysm is a nightmare for the surgeon, because the surgeon is a dissecting aneurysm and the surgeon can hardly find its neck. It's a major vessel. So he puts a clip, there is a huge bleed, and where to put the clip? The major vessel gets, either the parent vessel has to be occluded, or the patient suffers a large infarct, or it's a catastrophe. So in these cases, the endovascular management has a total paradigm shift. We just put in this flow diverter stent, and you see, this was the aneurysm, put in the flow diverter stent. This is the result 3 months later. So absolute healing. No outside, nothing opening from the skull, and these have changed the way we deal with such aneurysms. This is one of our papers with surpass device. And not only these, day in, day out, newer devices are coming to deal with easily with such poorer, aneurysms, bifurcation devices, contour, the web devices. These have intrasaccular flow diverter. So they have changed the way we used to deal with aneurysms in the past. Not only that, we also should be aware that strokes can also be due to vasospasm, and following aneurysmal subarachnoid hemorrhages, and endovascular also helps. The newer therapy also helps it to deal with that. What we do is we chemically vasodilate these vessels by nimodipine and milrinone intra-arterially by injecting. So this is how we do it. Sometimes we go for continuous infusion. Yes, vasospasm is a bad disease, but we deal it like strokes. And sometimes 3 times a day or twice a day vasodilatation is done to save the life of the patient. So not all bleeds, as I said, are hypertensives, and atypical bleeds need to be found out in strokes, because they may have AVMs also, AV fistulas, just like this. And once you identify that, not everyone needs a surgery, not everyone needs a radiotherapy. Some can be easily managed by injecting a glue or an onyx or a squid, and you can just close these abnormal vessels and make it absolutely clean. These are pile fistulas. So just few more things, that not all strokes will come to you in the acute phase. Some will come to you in stroke clinics. So we have this patient who was a young guy, diabetic, and in diabetes you have huge chance of atherosclerotic stenosis. So this guy had recurrent episode of right-sided weakness more like a TIA, getting improved. And he was having MRI and CT angio, but repeatedly nothing was coming out, Why? Because the area which was stenosed was guarded by bones. So a lot of artifacts do come in this area. So a DSA can give you a very quick answer whether you have a fixed stenosis, and especially important for diabetic population. So these intracranial stenosis now, if recurrent stroke is happening, we can easily dilate. Just like cardiology, we can put in a wire, do a balloon angioplasty, just put in an intracranial stent. Nowadays, we are putting balloon-mounted cardiac stents inside the brain, drug-eluting stents. Look, very good outcome, and the patient does not have recurrence of TIA ever after. Similarly, extracranial stenosis, carotid stenosis, very, very common in diabetic population, in smokers. So you should be aware, when you have a dynamic stroke, hemodynamic stroke, a stroke having a beads appearance, in a watershed territory infarct, either an external watershed or an internal watershed or recurrent TIA in one side, give it a thought. Do an imaging of the vessels of the neck as well. Not only Doppler. Doppler is important, but it also depends on the operator. So sometimes if you are more suspicious, go for an MR angio or CT angio, preferably a DSA if you are suspicious, yes, am I not missing a stenosis? Because sometimes stenosis may be missed in USGs. So because these are treatable entities, reversible entities. Now, not all strokes do happen in the brain, some do happen in the spine, and they may present to you with paraplegias. So do give it a thought also when paraplegias are acute in onset, vascular in origin, whether there is any vascular cause, because this can also be managed by the endovascular route. Not all strokes need treatment. Some strokes, just need, understanding the pathophysiology. 2 minutes. So, like in this case, we had an occlusion of the M1. You can see the huge amount of collaterals. So what we did was we just maintained the hydration, just gauged the collaterals and kept the patient supine so that the collaterals stabilized for the next 48 hours, and the patient did not have an increase in the stroke. So there are variants, like you can have Moya Moya variants, you can have Indian variety of Moya Moya, you can have some fixed chronic stenosis in diabetic population, in high atherosclerotic population, and these patients, individualized care to understand how the brain is dealing with the pathophysiology of ischemia is crucial to the management. We should not be mechanical in pushing the stent and doing, whatever in a single thought process. It cannot be protocolized very simply. So my take on newer therapies is like this. So we should know when to stop, my experience, when not to intervene, and depends on the place and the local rules of awareness, because we are often subjected to media trial, and we live in a place or practice in a place where vaccine is questioned over the disease, the COVID vaccine. So the need of the hour is a proper stroke unit, the individualized care and stroke rehab and holistic approach. So newer therapy should not only base on intervention. Something more is also needed. What is that? What is the difference? So not all patients will come to you with an acute phase. So I think neuroprotective therapies should also be projected and looked forward to. We are having huge supply of neuroprotective of late. Many are in phase 3 trials. Many we are using often. Some we are getting very good results, but more trials needed to focus on this molecule. So the targets are various, like inflammation, oxidative stress, blood-brain barrier, excitotoxicity, apoptosis, autophagy. This molecule has come into play by various trade names like Centrivive, like Crosta, and it claims various molecules, most importantly sprouting of collaterals. Also we have the recent advent of another molecule called sofateltide, which has also an IV molecule post-stroke, neuroprotective, having some sort of beneficiary effect. So I think at the end, my last slide, it's a hard work intervention, but at the end, when the patient wins, we all win. If the patient outcome is bad, we can say we gave our best try. Thanks a lot.
Thank you, Apratim, for such a nice presentation. So we have in stroke, IV thrombolysis, tenecteplase, mechanical thrombectomy, and others, plus newer therapies. Yes, so well highlighted. If there is any question or comment, is welcome.
Right, sir. So it's a very, very common situation, very common situation. So unfortunately, many a times we find in our emergency, the cardiac call is made, the brain code is missed. So we often are referred the next day when the whole paradigm is done. Most importantly, I would say that it's such a common scenario that the emergency now, we are more priming to gauge both at the same time, because if it's in the acute phase, thrombolysis may work for both the cases, number one. Number two, again, the decision making for as part of the stroke is concerned is in the same cath lab, you can tackle the heart as well as the brain. So obviously the brain gives lesser time maybe than the heart, so gauge both. If you find that the large vessel is involved in the brain, we will give the thrombolysis if it satisfies the criteria, open the large vessel, and at the same time have the cardiologist on board in the cath lab, so to tackle the cardiac part as per his recommendations. If it is not a large vessel, if it's a small vessel stroke, we may only thrombolize and wait. If it's a medium vessel stroke, I would rather try to open it up if it's in a important supplying cortex of the brain. So obviously, for the if it's given for an acute myocardial infarction, for example, in tenecteplase, our dose is 0.25 milligram per kg body weight, and I think the cardiac, if you give the cardiac dose, it satisfies both. So basically, we don't bother about that. So whatever the cardiac advice for the thrombolysis part is taken, that should be taken care of. We are more bothered in stroke whether it's a large vessel or a small vessel. If it's a large vessel, if you thrombolize, yeah, so in antiplatelet, I have something to say here. So suppose you have both cardiac and a cerebral. So have a look in your sequence. What we do is we immediately try to, now we are more and more trying to localize in our CT angio or MR angio when we do the protocol, whether it's an ICAT, because you see the latest trial have come out with tirofiban versus alteplase for acute strokes. Why? Because as I showed cases, there might be scenarios where you might have to put a stent in the brain in the acute stage if it's an ICAT, because however much you take the clot out, the vessel will keep collapsing. In those cases, if you thrombolize, you can obviously not screen out all cases. These are all within the invited commas. But if you can screen out those cases that this is having ICAT, so I may have to put in a stent as a rescue on table. So it will be preferred if you can put in a GP2B3 antagonist if the patient obviously doesn't satisfy the thrombolysis criteria for cardiology. Because then it might help me, but these are controversial statements. You know why? Because till now the article is for bridge thrombolysis, which favors, because if we generalize our statement that if I say that you don't give alteplase to this patient, you try to give tirofiban for this patient, this makes it very clumsy, not possible as a whole screening tool. So that's why it is still not in the guideline.
No, the question is probably double antigen. Do you prefer in acute stroke or single antigen?
So
single antiplatelet.
So if as the guideline says, sir, minor stroke or TIS. As per that, 21 days dual antiplatelet. Yes. But apart from this, no other benefit. Okay. So first question is, if you have a stroke without a large vessel obstruction, for that do you thrombolize? So if it satisfies the thrombolysis criteria, if the patient is even having a low NIHS or a low stroke scale, if the patient is having a disability, thrombolize if it satisfies the criteria. If the thrombolysis criteria is there within the window, if there is disability, that disability may only be in the face, but that face may be that of an actress or an air hostess, which is important, not of mine, which is not important. So for that, thrombolize. Right. Yeah, that's what I'm saying, sir. Even if you don't find an obstruction, if you clinically, because obviously either in DWI or clinically you have found a stroke, that's why the stroke could have happened. Even if you don't find an obstruction, it might be a small vessel occlusion which you don't record in your angiogram. So if you clinically, if you have a stroke, for stroke thrombolysis, angiogram is not the criteria. So only the clinical feature, the disability is the criteria. If the patient is significantly disabled because of that stroke, if it satisfies within the window and the contraindications ruled out, you have to thrombolize. But in stroke, sir, we have to thrombolize if it produces disability. That may be a false code, doesn't matter. We have already ruled it out by a CT. That's what I'm saying. So you don't do an angiogram for a stroke. I understand, sir. I understand. But yeah, you are right. So it happens in cases of spontaneous dissections. Patient may present with headache, but that is difficult to rule out. So for us, stroke, it is very things like you have a disability within the time window, CT normal, thrombolize. We don't do an angiogram.
Apratim, just couple of small questions. If you have a large vessel stroke, clinically, and on the CT there is no evidence of ICH, and you know this is a large vessel stroke, the NIHS is high, the aspects is low, instead of directly thrombolizing, supposing an interventionalist like you is on ground, you don't have to come from a long distance, or the patient doesn't have to be shifted from another place to your center. It's happened in the hospital, you are there. Would you prefer to go for a mechanical thrombectomy outright, or would you prefer a bridging thrombolysis before you go for a mechanical thrombectomy?
Yeah,
the drip and ship is very effective if the interventionalist is not there, or you have to shift a patient from one place to another. But a large vessel stroke, if you thrombolize, there's a very high likelihood of a bleed inside. Would you prefer to open up the vessel directly without going for a thrombolysis?
Yeah.
The old concept about the bridging thrombolysis, making the clot more friable, easy to suck out, probably doesn't exist anymore. So would you like to open it up?
Yeah. So as an interventionist, obviously I would like to, if I'm there, it's a large vessel as I've showed, only CT straight to the cath lab, and mostly people are shifting now to CT inside the cath lab. So this is the best thing for us as an interventionist. Two things. Number one, it decreases the chance of bleed. Number two, it gives me more cases and gives me more thrill, because I'm interventionist. I would like to open it up. But coming to talk with evidence, what does evidence say? The evidence says three things. Number one, there are 3 trials till date on direct to cath lab. So one is the DET trial, the SKIP trial. So all these trials basically tell you that, okay, directly shifting to the cath lab is no way inferior to thrombolysis followed by thrombectomy. However, taking all the data so far, till now, it has been seen bridge thrombolysis is still the preferred approach. There are 2 reasons. Even if the thrombectomy person is there, the reason is the cath lab may not be immediately available. So you are denying the patient a few seconds also, number one. Number two, while doing the thrombectomy, you always stand a chance of some clot shreds going distally. So the claim there in their article is that thrombolysis takes care of that. Number 3, it somehow makes the thrombus more liable to take out by a stent retriever.
Do you feel that? I mean, as an interventionist, do you feel that the clot is easier to draw out after a thrombolysis?
I tell you my experience, which is of the guidelines, of the record. So I would tell you, if the patient can, can afford, if I can do a Solumbra, I am confident of taking out any clot. Last day I took out a clot at 16 hours. It was a hard clot, elderly female, 16 hours, but she is doing excellent because we have recanalized. But at the same time, we can find the more the time is spent, the clot gets hardened, and also depends on the clot morphology and the build. So at times we had to modify. So we have done 2 passes, it is not coming out. I am pouring some heparin, I am pouring some tenecteplase inside the clot, and then it came out. These things have also happened. So in a clinical forum, I am supposed to talk with evidence and trials. That's why I will always put my statement that way. But if you ask me, yes, I will always like the patient in my cath lab at the earliest.
Thank you, Apratim, for that wonderful lecture. If there are no further questions, I think we'll wrap up. I thank the organizers for giving us the opportunity and hand it back to them.
Thank you, Speaker, sir. Thank you, Chairpersons. I would like to request the Chairpersons to felicitate Dr. Apratim Chatterjee. I would like to invite Dr. B.P. Pandey to felicitate Dr. Apratim Ghosh for chairing the session. Thank you for the enriching session. Thank you, chairpersons. With this, we come to the end of the first day of the scientific session of Howrah Town Diabetes Study Society. And I would like to invite Dr. Sanjay Shah, President, HDSS, to give a brief closing for today's scientific session.
I think I don't have any words, essentially, for being able to manage such a wonderful scientific session today, all because of the cooperation that we have received from all my foundation members, Howrah Diabetes Society members, members who have taken the pain to come all the way here and be part of the scientific session, as well as to the pharmaceutical industry who have, by scores of them, perhaps 2 or 3 scores, so 40 or perhaps 60 pharmaceutical industry who have managed to chip in and support our endeavor, okay? And it truly has been enlightening. I started my today by talking about education, which definitely has something which we all continue to do. And I think learning about so many different subjects and from the specialists themselves, it truly has enriched my association with so many different colleagues as well. And I hope at the end of this conference, which is going to be tomorrow, and I'm sure it's going to continue to be as good as today, we perhaps will be empowered to do better practice and serve our society at large. So with those few words, thank you once again for hosting it so nicely throughout the day. Thank you very much. Big hand. Thank you.
Thank you so much, everybody. Good night to all. Let us all meet tomorrow for a great scientific fiesta.